So hi, welcome everyone. Tonight we have with us Dr. Eric Trumble and Dr. Shawn Vuong out in Sioux Falls at Sanford Health. I'm really excited that you guys are here to do the Q&A with us tonight. Before we get started, I usually like to have the physicians kind of introduce themselves, why they're interested in Chiari, how they got involved in this particular type of surgery and why they are interested in treating these patients. So I'm going to let you guys kind of start by talking about that.
I'll let Dr. Vuong introduce himself and then I'll follow.
Okay. Hello, everybody. Shawn Vuong, neurosurgeon here at Sanford, as this was already mentioned. And I guess my background and interest in Chiari essentially lies in just my training background. My background training is in Cincinnati, and that was one of the Chiari centers started by John too, and so that background and training it just kind of carried forward and continued my interest. So.
Yeah. So for those of you who I've spoken with before, you know, Chiari has been an area of interest for years for me. When I practiced in Florida for about 25 years. I've been in Sioux Falls for 2. And Dr. Vuong was one of the reasons I came up here. So we're the 2 fellowship-trained pediatric neurosurgeons in South Dakota. We have a monopoly in this area. The pediatric guys tend to have a greater interest in Chiari for a couple of reasons. One, the most common brain tumors are the most common solid tumors in kids. The most common location in brain tumors is the posterior fossa. So we're essentially doing a Chiari approach, except going deeper for a brain tumor. So it is a common operation that the pediatric neurosurgeons will do. 2, Chiaris tend to be congenital. So my title when I was in Florida was Director of Congenital Neurosurgery. The idea was that we would take care of specific congenital issues, tethered cord, Chiari, syrinx, things like that. So we've had a great deal of interest in Chiari for years. When I was in Florida and Orlando, it was everybody wanted to travel to Orlando, so it was easy to have everybody come and see us there. And then in Sioux Falls, we're trying to do the same thing, essentially make a Sanford Center for Chiari care. And I know there's a lot of discussion nationally about what are we going to call Chiari centers? How do we create them? So when we had the Chiari retreat back in 2018 in Orlando, that was part of the discussion. And there really is no national conversation on how to do that, but certainly you want somebody who at least knows how to pronounce Chiari. One of the simple things was I had to train my staff 20 years ago how to pronounce Chiari. And so we would get lots of calls from patients who just said, oh, you know how to pronounce it. Now, good, you must at least know what it is. You know, just having some education, certainly in the last 20 years, we've done much better education, but this is part of the outreach where we're trying to do as much education on it as possible. And, you know, we've done 2 previous ones with you as well that you've been kind enough to videotape and have on YouTube and do all those things. So when Kathy came out with us, we were fortunate to have her, and hopefully we'll be able to start doing these live again next year.
From your lips to God's ears, we'll see. But, yeah, so that's awesome. And I know that's something that we're really interested in too, is making sure that the medical professionals as well are getting all the information that they can about these conditions, because they're really, really, as I'm sure we're going to get into, complicated. And a lot of people think that they're not, and that's just not the case. So if it's okay, I'll just get into some of these questions. Are we good? All right.
Absolutely. That'd be great.
Sure. So I think I usually try to stagger these and put them into little categories, but they're sort of all over the place. So I'm just going to start with number 1 here. What are the postoperative chances of developing arachnoiditis from intrathecal blood contamination, which is an extremely targeted first question, so I'll let you go.
Well, and Caitlin, if you don't mind, we're going to sort of try to, since you've got both of us, we're going to sort of try to do a 2 wise men, hopefully 2 wise men conversation.
Well,
so we'll tag team these, and Dr. Vuong will give his opinion. Dr. Vuong is a couple years out of fellowship, but he's more newly trained than I am, so we'll sort of talk about as much of the new stuff as we can here. And what we think state of the art is. So we'll tag team back and forth if you don't mind.
That's a great idea. Love it. go ahead.
Okay, so I'll just get started with that question first. Essentially, we're asking about the development of arachnoiditis, which is just the inflammation inside the covering of the brain, the arachnoid, and just an inflammation and maybe even like a scarring area that happens in there. And a lot of people and a lot of talk has been about how postoperative blood can cause that, because the breakdown of the postoperative blood incites an inflammation response, and then that in and of itself can create a scarring and arachnoiditis. And so essentially that's what it is. And I just wanted to, we got these questions earlier, and so I wanted to pull a paper, and we pulled two papers. One was a review paper, and essentially like in that first review paper, they talk about and define arachnoiditis, but it's not targeted towards Chiari's, and none of these papers will be targeted towards Chiari's because arachnoiditis is so rare. And in fact, it's so rare that the review paper couldn't even comment on how often it happens. And so to try to get more of a sense of how often does arachnoiditis happen, there was a very interesting paper that came out of Mayo in 2017 where they looked at all of their imaging studies in the spine and brain from 1995 to I think 2013. To 2013. So thousands and thousands and thousands of imaging studies. And they found 29 patients with arachnoiditis due to either trauma or prior surgery. And so just to give you a sense of like how often that happens, 29 and thousands over from 95 to 2013, we're talking about a very rare diagnosis to begin with. And so that should kind of give people an idea that we don't even, in my practice, I don't even discuss arachnoiditis as a complication. I just kind of lump that into, and other rare complications may happen. And so that's kind of the basis of the answer. So to get to the answer, it's extremely rare, I guess, is what I would say.
Yeah.
Yeah, and I would echo that. So for those who are language scholars, arachne is spider in Greek, so it looks like a spider web under the microscope, and that's what the arachnoid is. It's a tissue paper thin membrane that follows the gyri and sulci, the lumps and bumps in the brain. There's a lot of discussion about how aggressive to be, and we'll go into that a little bit later about do you open the dura, not open the dura. The arachnoid is the innermost layer of the dura. We've had lots of national discussions about how aggressive to be. So Dave Frim, who's one of the well-respected neurosurgeons in Chicago, has pushed for years opening the dura but leaving the arachnoid intact. The idea of leaving the arachnoid intact is that you're trying to minimize the risk of a spinal fluid leak because the arachnoid is the final layer holding the spinal fluid in place. And that would also reduce the risk of arachnoiditis, although that's not the reason not to open the arachnoid. The reason is to minimize the risk of a spinal fluid leak. Most of us who open the dura don't keep the arachnoid intact. And the reason is there is some literature to saying there's up to a 20% risk or chance of arachnoidal veils. There can be a little tissue paper thin membrane, which you can't see on the MRI, which is blocking the exit of CSF from the intracranial space. So the obex is what allows the pathway where the CSF goes from the fourth ventricle into the subarachnoid space in the spine. So subarachnoid, arachnoid, all part of that same location. I would agree that it is a rare concern. Certainly we try to minimize how much blood gets in there, but it's impossible to do bloodless surgery. But that will sort of lead us to the second question. So if you want to go to the second question, Caitlin, and we'll talk a little bit more about arachnoiditis there.
Absolutely. So the next question is, if a patient presents with intracranial hypertension, Chiari, and arachnoiditis, would you still consider surgery in that patient?
You want me to start with that one too? Okay. So when we have a patient that has all three of those diagnosed, well, so first of all, again, arachnoiditis is very rare. So it's more common to see a patient who has both intracranial hypertension and Chiari at the same time. Once we start to get into that process, then you're starting to develop concerns about like the chicken and egg problem. Did the intracranial hypertension start first? Did the Chiari cause or lead down the road to causing intracranial hypertension? And so one can lead to the other. A lot of times intracranial hypertension patients will have an element of Chiari. And so the question is what should you really do? Can you do anything for them? And I guess I would say that, yes, we do consider surgical intervention for those, but in my mind, we have to treat the intracranial hypertension first because, and I'm sure that Dr. Trumble will get into this more too, but I would get concerned that decompressing the Chiari and opening up the CSF space may lead to more complications as a result of a high pressure pushing down into a low pressure area and causing more either brainstem or cerebellum or spinal cord damage. And so I would say, yep, we still do it, but you would have to start to consider the surgical treatments for intracranial hypertension.
Right. So often we'll talk about these same issues. So intracranial hypertension, IIH, idiopathic intracranial hypertension, the old phrase is pseudotumor cerebri. Pseudotumor cerebri is really a term from the pre-MRI era. So they'll often have headaches and papilloedema, swelling behind the eyes. In the MRI era, we know they don't really have tumors. So pseudotumor cerebri has now been replaced by idiopathic intracranial hypertension. If you have elevated pressure in your head, there is one hole the brain can be pushed through, and that's the foramen magnum, the hole at the base of the skull. So if your pressure is up and you're pushing your cerebellum down through the foramen magnum, you get a Chiari malformation. I have seen some people talk about trying to decompress the Chiari and open up the spinal fluid pathways so that you release the intracranial hypertension. I've never seen that happen. So I have seen patients that I've decompressed for the Chiari not knowing they had elevated cranial hypertension who developed it later, and that's probably 5% or so of patients with Chiari. So if you have persistent headaches after a Chiari decompression, I will often recommend checking your intracranial pressure, and the way we usually check is a spinal tap. There's some concern about whether you should do an LP in patients with cerebellar tonsil ectopia. Again, I've never had an issue with a small volume tap, 10 cc's or so. All you're really trying to do is check what the pressure is. And if the pressure is elevated, then you need to treat the elevated pressure. And usually that's done by neurology initially. So they'll try diamoxacetazolamide is the generic name for that, something that's going to reduce your intracranial pressure. If they fail, then we have a discussion about how aggressive are we going to be. And I tend to fall on the more aggressive side in terms of shunting patients. So putting a ventriculoperitoneal shunt, and this is a shunt for those who haven't seen a shunt before, but we use ones with a Rickham reservoir, then it has a valve, so they have a certain amount of pressure inside their heads. For the idiopathic intracranial hypertension patients, I always use a programmable valve because we don't know really what pressure setting they want to be put in. There's about 100 different brands of shunts, which is telling you nobody has exactly the right answer. And in the idiopathic intracranial hypertension patients, their pressure goes up. And again, this is a full hour talk we could go into, but their pressure goes up it's idiopathic, so we don't know for sure why, but we know in some patients it is due to venous hypertension, so you want to make sure that the sinuses, the largest draining veins in the brain, are patent. If they're not patent, you can stent those to try to improve them. We know that it's more common in heavier patients. So if you have a BMI over 35, if you drop your BMI down to 25, you reduce the incidence of idiopathic intracranial pressure by about 50%. So about half those patients can get by without a shunt with improvement in symptoms. The problem, of course, is if you feel horrible, which most idiopathic intracranial hypertension patients do, you're not going to be working out, you're not going to be losing the weight. So it becomes a vicious cycle sometimes. Probably 5 years ago, so the Florida Neurosurgical Society has a point-counterpoint discussion annually. And there was one year where I was the pro-shunt and we had a neurosurgeon from Miami who is the anti-shunt. Shunts can be very frustrating both for physicians and for patients. So I don't know if you can see, but there's a bunch of little holes at the tip of the catheter. It's not showing well, but there's about 20 holes at the tip of the catheter. It's what goes into the ventricles and lets the spinal fluid come down. Usually in patients with idiopathic intracranial hypertension, their ventricles are smaller than a centimeter. So you can get tissue to grow in there, block it, and then you just get into recurrent issues. In the setting of Chiari is a relative indication for a ventriculoperitoneal shunt, a relative contraindication to a lumboperitoneal shunt. So shunts are just trying to drain spinal fluid somewhere else. That somewhere else is usually the peritoneal cavity, so that extra spinal fluid is absorbed by veins on the inside of the intestines, just like regular fluid that they drink is absorbed by, veins on the outside of the intestines with the VP shunt, veins on the inside of the intestines with regular fluid that they drink. So I'm giving you a long answer to say this is a very difficult setting that we use, and you need to have a long discussion with the patients. Most of us will treat the idiopathic intracranial hypertension first, hoping that we're going to improve the Chiari, simple fluid dynamics, not brain surgery, simple plumbing. If you're sucking things up, you may pull the Chiari up. If you're sucking things down or have pressure pushing things down, you may make the Chiari worse. The arachnoiditis complicates everything, and if you have true arachnoiditis, treatment is very complicated. I'll sort of go into that a little bit more. If you have postoperative arachnoiditis, you've got inflammation. Again, very rare complication, but that is the one setting in which I like a cine MRI, cinema, flow study MRI. If it looks like you've had a well decompressed Chiari, but you're still having symptoms, I like using a cine MRI because you're looking at flow through that area. So the arachnoid is tissue paper thin. It may be too small to see on the MRI, but if you see obstructed flow, that is somebody who may benefit from a redo decompression, assuming they don't have idiopathic intracranial hypertension. The frustration is we don't have any way to stop scar from recurring. So if you have a postoperative arachnoiditis and you're symptomatic from it, there have been patients where I have gone back, particularly if they got better for a little while and then got worse. So we know that the issue is the Chiari. I have gone back and tried to break up the scar. The success rate's about 50%. So there's a much higher failure rate there, and we don't have any means to eliminate the recurrence of arachnoiditis.
Yeah. There's a really interesting question that was just asked. So it's actually kind of two questions. So one, this is really good. How is it determined if a shunt is draining the right amount of CSF? And then how reliable is papilloedema in diagnosing IIH?
All right, Dr. Vuong's been going first on both of those. We'll go first on both of those. So papilloedema is usually a late finding. The only way to truly measure elevated intracranial pressure is to measure the intracranial pressure. So usually that's done by an LP. You can drill a hole in the head and put an intracranial pressure monitor, but most people would rather have a needle stick than drilling a hole in their head. So an LP is the diagnostic test of choice on those. If papilloedema is present in that setting, we always send them to ophthalmology. Ophthalmology does dilated exams. They can see better than we can. But assuming they have true papilloedema, and there are things like pseudopapilloedema that usually the ophthalmologist can differentiate. But if they have true papilloedema, that's an indication for an LP to make sure they don't have elevated pressure. If they have elevated pressure, we send them to neurology. Usually neurology does medical management. If they remain symptomatic, a repeat LP while they're on treatment, Diamox is sort of the minimum treatment, is done. And if they remain symptomatic, then you have a discussion on how to treat them. So idiopathic intracranial hypertension is a life-altering issue, as is Chiari, rarely a life-threatening issue. For idiopathic intracranial hypertension, the really big deal you worry about is if papilloedema goes untreated, you can become blind. So if you're having visual changes over time, you can have permanent issues. The most rapid treatment for elevated cranial pressure is an LP, where you just drain some spinal fluid off. There are other treatments for papilloedema. So if you have elevated cranial pressure, you can do optic nerve fenestrations. That's done by an ophthalmologist. We don't have anybody in South Dakota who does those. We send them to Mayo if they do it. So Florida has a population of 30-some million people. We had one group, Baskin Palmer, down in Miami that did them. So it's very rare. I've been here 2 years. I've had 0 patients have optic nerve fenestrations. I think I had 3 in 20+ years in Florida. So usually they have other symptoms, headaches and things like that. And so you want to treat the reduced pressure. You want to try to reduce the pressure. Can you show us the questions again? Do we have the questions? Because I'm not sure I answered everything for you there.
Well, this one came up live, so
Oh.
you
Yeah.
wouldn't get that one.
So did I answer both pieces?
No. So the other question was, how do you determine if the shunt is draining the right amount of CSF? Yeah.
Experience. Talking to the patient. There's actually times it helps to talk to the patient and figure it out. So the neurosurgeon always likes looking at the patient's insides, but in idiopathic intracranial hypertension, you can't tell. There are some, you can't tell because most shunts are put in for hydrocephalus, fluid building up. Idiopathic intracranial hypertension is pressure building up, not fluid building up. So usually the imaging studies don't change in that patient population. We'll usually do images, CT or an MRI. We'll usually do a shunt series. This is a piece of plastic. We'll make sure it doesn't break, although that's pretty rare as well. And then we can we can program the valve. So the valve I usually use is a Codman Hakim programmable valve. It has 18 different settings, but again, there's multiple different valves out there. So it's just personal preference of the neurosurgeon. And if the patient remains symptomatic, remember we talked about 50% of these shunts failing. If the patient remains symptomatic, you need to check pressure again. So that usually means they get another LP. And if the pressure is elevated, you talk about revising the shunt. And most of the time, the issue is a proximal issue. The part inside the head has tissue grow in and block those holes at the proximal portion.
Okay.
Yeah, I completely agree with all of that. I guess I'll answer the second question first. So how do you know how much drainage there is? I completely agree. The only way to know is to talk to the patient. If they're having too much drainage, which is almost unheard of in intracranial idiopathic hypertension, because I feel like you're essentially draining as much spinal fluid as you can drain, but in those patients, the ventricles are so small that you can only drain so much at a time anyway. And so you want to drain as much spinal fluid as you can because you're trying to treat the pressure. You're not treating a fluid buildup. So there's not really a good reason to just continue draining. And I haven't met a patient yet, and maybe you have, that has low pressure headaches after placing a shunt because of intracranial hypertension.
I would agree. That would be very rare.
Yeah, so I haven't met that patient. So I would say go ahead and try to drain because they usually don't get those symptoms. And those symptoms are when you stand, you kind of get this pulling sensation. And every time they sit upright, they feel they've got too much of their fluid shunting. And that almost never happens in this particular pathology. I've never seen it. And I would make that argument to say that that's because this pathology is completely different, even though we don't understand it. We just don't, there's just no way, because you're trying to treat a secondary problem. And as Dr. Trumble alluded to earlier, there are some studies that are showing that this is a venous drainage problem. And actually, the last time I was at a hydrocephalus meeting a couple of years ago, there was a very interesting neurologist that was there. And he was talking about he's on the committee for the astronauts, and they've been starting to see that astronauts who are in space for greater than 3 months at a time are developing a syndrome very similar to idiopathic intracranial hypertension. And so that I think brings even more value to the thought process of this might be a venous drainage problem, because one of the main complaints that the astronauts have once they get into a zero gravity environment is that they have flushing of the face and they don't have as good a venous drainage. And so I think that the shunt is not really treating it. And this is kind of where Dr. Trumble was talking about him being more aggressive with heading towards shunts. I tend to be on the more conservative side, treating my patients with the shunt only because I'm the glass half empty guy when I'm reading all the literature and thinking through this. I see that some patients do get relief with their headache, but it doesn't seem to last. And the problem with the workup of the shunt over and over and over seems to make the patients more miserable. And we had this saying that a shunt is a curse, but idiopathic intracranial hypertension can only be treated so many ways. And so unfortunately, the shunt is one of the only options we have, again, with the optic sheath fenestration if patients are starting to go blind, which I feel like is the main indication for placing the shunt. And so, but unfortunately, there's no ophthalmologist to do them, even in Cincinnati. So the metro area of that is 2.8 million, and the whole area, I don't think we had maybe one ophthalmologist in the state of Ohio that did those, and there definitely wasn't one in the Cincinnati area. Even with a Chiari center there that had been well established, there still wasn't ophthalmologist that did those, and so that makes it really tough to allow and give the patients as many options as you can for alternatives.
Yeah. There was an interesting question that someone asked in the chat I want to get to before we kind of move away from talking about the arachnoid and stuff like that. Have you noticed any differences in like the strength or the stretching of the dura in people with connective tissue disorders versus those who don't have that?
Yeah, so that's part of my shtick. I firmly believe that most patients with Chiari's has a connective tissue disorder. The trendy diagnosis now is EDS, Ehlers-Danlos syndrome. 10 or 20 years ago, most of the patients were diagnosed with fibromyalgia. Now we're talking about EDS. It's my belief that 10 or 20 years from now, we'll have another couple of diagnoses that we're figuring out. So we are evolving. Remember, we've only had MRIs for 20 or 30 years. So Chiari diagnosis really is in its infancy. And we may talk about syrinxes a little bit later as well, but when I was in training, we shunted a lot of syrinxes. We shunt almost no syrinxes now because we understand the relationship with Chiari's and syrinxes. Again, the Chiari and Syringomyelia Foundation definition. So I treat all of my Chiari patients as though they have a connective tissue disorder. It is clear the incidence of pseudomeningoceles, of spinal fluid leak in the Chiari patient population is higher than those that we do posterior fossa decompressions for other reasons. So I can't tell you the last time I had a spinal fluid leak in one of my brain tumor patients, and I'm probably doing a brain tumor every 2 months. I'm doing a Chiari 2 or 3 times a month. But the incidence of pseudomeningoceles of spinal fluid leaks in the Chiari patient population, national numbers are about 10%. And that's been my experience as well. So there's no question that there's a higher incidence of connective tissue issues in the Chiari patient population. And again, we'll talk about craniocervical instability a little bit later as well, but that's the ligamentous laxity that we see in a lot of these patients. And again, the ligamentous laxity that you see in a lot of the EDS patients with the hypermobility. So it is my belief that a lot of these patients have connective tissue issues. I am not aggressive in the workup of the connective tissue issues because there is no good treatment. So I treat all the Chiari patients as though they have a connective tissue issue. Use longer lasting sutures, try to put more stitches in, do all that stuff, be a little bit more delicate, although I'd like to say we're delicate on all of our neurosurgeries, but extra delicate in the Chiari patient population. And so whether the arachnoid / dural issue is purely related to connective tissue or whether this is chronic thinning, sort of like water on a stone, the whole reason we're doing the decompression is that cerebellar tonsils are down there, so that they've been impacted, and the dura is between the cerebellar tonsils, which are too tight, and the skull, which is immediately behind it, immediately posterior. There's probably a combination of connective tissue issues and chronic pressure that thins the dura, but there's no question there's a higher incidence of spinal fluid leaks. For the exact same operation, we actually go deeper for the brain tumor patients. So there's a higher risk in the Chiari patients than the patients we do posterior fossa craniotomies for other reasons.
Anecdotally, though, do you feel like the EDS patients that are true, like fully diagnosed by another specialist, come in and do you think they have thinner dura?
I have not been able to appreciate any difference intraoperatively. Have you?
No, I can't say. Yeah, that's why I was thinking just in that population that has been positively diagnosed by another specialist. I don't think I've seen it, but in Chiari patients, I agree. It does seem like the dura's thinner.
Yeah. So remember, we're talking about a millimeter here. So when we do the operation, we both operate with loops. So we're at least a 3 to 4 times magnification, sometimes under a microscope 10 to 20 times. But even if it's 50% thinner, that would be hard to pick up at a surgical level.
Yeah. You kind of touched on this, and again, this came up in the chat, so I want to just ask it before we move on. Obviously, Chiari is considered congenital. but there are these instances where the symptoms come on over time. So you kind of alluded to it when you said that over time this kind of trauma might be building. And I guess what's the mechanism of that? Does it have anything to do with those connective tissues, or is it something completely different?
You want to go first?
Yeah, I'll start with this one. So there's essentially, that question gets at the root of the diagnosis of Chiari, primary Chiari and secondary Chiaris, which I'm sure you've heard many, many times before. A primary Chiari is a congenital Chiari that we've seen, and we don't really know, is it secondary to, again, congenital connective tissue disorders, or some kind of small posterior fossa, or the ligamentous laxity. The secondary Chiaris, I don't think that this is what this person was trying to get at, but the secondary Chiaris are Chiaris that happen as a result of IIH, as we already talked about, or lumbar puncture that was a little too aggressive, or some kind of CSF loss as a result of surgery, or something like that that leads to spinal fluid being shunted down into the spine and causing and pulling the cerebellum down, or a pushing of the cerebellum down, maybe from a tumor or something like that. So, but I think I'm getting back to the crux of that question, which is, how do they develop over time in an adult? I think some adults don't know that they even have one because they've never even had an MRI. So they just didn't have the symptoms before, because over time the cerebellum has settled, so to speak, and then as the CSF isn't able to move through the foramen magnum, they start getting the symptoms. And so they had the Chiari the whole time because it was congenital, but it didn't develop symptoms until stiffening of the tissues took place, or a change in their lifestyle, or either that ligamentous laxity. So again, for unknown reasons, the cerebellum has slumped down and caused the CSF not to flow through. I think that's part of it. And then another part of it is the ligamentous laxity patient, connective tissue patient that slowly has, like you said, like micro traumas, and then that has developed over time and it led to a sinking of the cerebellum and causing a CSF flow problem, which then becomes symptomatic.
Yeah, I would agree. So we know, we believe that most Chiari patients are congenital, that it looks the same when you were a baby and it'll look that way when you're an old person. Why patients become symptomatic is unclear. We know the vast majority of patients with Chiaris never become symptomatic. So if we look at the routine screening MRIs, more than 80% of patients with Chiari never need to have a decompression. So the vast majority don't need surgery. So again, we're talking to the Chiari and Syringomyelia Foundation, so we know what the Chiari is, but the Chiari, the cerebellar tonsils going through the foramen magnum, the analogy I usually use is a cork. That cork can become more and less tight for reasons we don't completely understand. We know minor trauma will do it. So I've had people with shoe boxes fall onto their head that became symptomatic. What's supposed to be where the Chiari is spinal fluid. What is there is the bottom of the brain. That's the definition of Chiari I malformation. So you have less of a shock absorber capacity. That's why you'll often have neurosurgeons get into the discussion. Can you play football? Can you do gymnastics? Can you do those things? For those of you who've seen my talks before, I have 7 kids of my own, but the goal is to lead a normal life. So I don't put my Chiari patients in any specific precautions, but if they're doing something and it makes them feel worse, they should stop doing it. So I've had people with Chiari who couldn't sing anymore. They couldn't hold the note because it raised their intracranial pressure. Couldn't play football because the chronic extension of the neck made symptoms worse for them. So certainly positional issues can do it. Minor trauma can do it. Usually we don't see a significant change in the anatomy related to a worsening of symptoms. And that becomes part of our frustration, is why are some people symptomatic with 5 millimeters of cerebellar tonsillectopia and some people asymptomatic with 20 millimeters? And that's something we don't know. And honestly, we may never know. One of the reasons I became a neurosurgeon is the brain is still a big black box. We're still learning a lot of this. The analogy I usually use is the heart surgeon. So the cardiac surgeons and the neurosurgeons are the surgeons that train the longest. The cardiac surgeons can do a heart transplant. They've gotten about as far as they can get. We are generations away probably from being able to understand the brain to that degree.
Absolutely. Yeah, that's why the brain is just so fascinating. Actually, so I want to go back to the questions that came in beforehand. because it sort of gets to what we're talking about too. The gist of this question is they had the decompressing surgery, and they had gone back in, and they were told that there was actually too much space created, so they had to put in that titanium sheet right there. So, but what the question boils down to is, can decompression actually cause the symptoms to worsen?
That one, yeah. So decompression can make the symptoms worse. I also thought that this was an interesting paper and wanted to get a more specific answer, or a question. So I pulled a paper for that, and that paper came out of Ohio State in 2014. It's called Surgical Outcomes Using a Wide Suboccipital Decompression for Adult Chiari I Malformations Without a Syrinx. And what they found was that 7% of their patients out of, let's see here, how many did they have in this one? You see the number?
I think 30.
30, yep, so 30 patients. So out of 30 patients, they had 7% of them say that they were worse after the decompression. And actually 13% when surveyed after they got all healed and all the way past surgery said that they wouldn't want to proceed with surgery again. And so, yeah, it is well documented that, unfortunately, and again, for unknown reasons, we don't really understand why some patients actually do get worse.
So part of the discussion I have, I don't know if you can see it, but part of my standard handouts are the Chiari Severity Index. So Chiari Severity Index was published in 2015, and it's looking at all, we're really talking about Chiari 1s here the whole time, but it's looking at the Chiari 1 patient population, and they looked at the likelihood that you were going to improve with surgery. So if you had classic suboccipital headaches, you were what they called a clinical grade 1. And in their study, 81% of patients got better, but that still meant 19% of patients failed to improve. The worst outcome were in patients with myelopathy, so evidence that there is spinal cord dysfunction. And part of the symptomatology that that person had in their question was talking about depth perception issues, hearing loss. Those are evidence of brain dysfunction. That's not just headaches, it's evidence of brain dysfunction. In that patient population, the surgical success rate was 58%. So if you reverse that, 19% failure rate, 42% failure rate. One of the things that I look closely for in my Chiari patients is there evidence of myelopathy? Is there some sign that there may be ongoing damage to the spinal cord below the level of resolution of the MRI? So if we see a large syrinx, if we see signal changes in the brain, those are indications for surgery. If you have a Chiari without organic changes within the brain or brain stem, spinal cord, depending how low it goes, that really becomes a symptomatic issue. For the vast majority of patients, the decision to proceed with surgery is symptomatic in nature. But if you're having myelopathy, so again, in infants, the most common way we pick up Chiari is a swallowing issue. So they have oromotor dysfunction. They're too young to say, "Mommy, I have a headache," or in adults we can pay attention to symptoms worse. But if they're having myelopathy, that makes me worried that there's some degree of damage ongoing below the level of resolution of the MRI. The MRI is the best anatomical imaging study that we have, but we know, based on most literature, and again, I usually quote this Chiari Severity Index, but there's multiple papers out there that talk about it. Once you go to myelopathy, you have at least a double failure rate in surgery. So something is happening. And it makes sense, although nobody's ever done that study. If the symptoms are going on for a week, you're more likely to improve than if they've been going on for a decade. So the longer they've been going on, the higher the risk of permanent neurological deficit, and therefore the higher the risk of surgical failure. My experience has been that it does not increase the risk of making symptoms worse. So that article that Dr. Vuong alluded to, that 7% getting worse, that would be very rare. I have had a couple of patients get worse, but if they're worse, I worry that something else is going on. So we look for a syrinx, we look for arachnoiditis or scarring that's blocking the flow of spinal fluid. We look for idiopathic intracranial hypertension. So I do an MRI on all of my Chiari patients about 3 months post-op. That's sort of when you hit steady state. That way I can make sure you don't have a spinal fluid leak and everything else looks okay. And we'll do it sooner if there's symptoms. But I want to be sure that everything looks okay. So I put them all on light duty. I don't want any Valsalva maneuvers raises your intracranial pressure. So I don't want them doing anything that makes their face red. So no heavy lifting, no screaming, shouting, any of that stuff that we can try to avoid if possible. And again, that's in order to try to minimize the risk of secondary complications.
Right. Sort of to this point, myelopathy is a big medical word. So
I'm sorry, Dr. Vuong's actually getting a call from the hospital, so we're going to trade spots here, and he's going to take care of that.
No problem. So myelopathy, to your point, that can be a big problem. So I guess if I were a parent and I were looking for signs of that in my child, and I'm not a doctor, what am I looking for?
Any evidence of brain or spinal cord dysfunction. Remember, the cerebellum is the bottom of the brain, is where the Chiari is. So coordination issues we often worry about, particularly getting worse. It's often fine motor issues. So I'll ask them what the quality of the handwriting is. Is that getting worse? Kids now are playing lots of video games. Is he having problems? It's usually a he playing the video games, but is he having problems with his video games? He's not playing as much. If they've got good fine motor control, it's unlikely to be specific myelopathy. In the younger kids, we talked about oromotor dysfunction, so swallowing issues. Sometimes it's a coordination issue with your tongue. So sometimes speech and learning to speak can be a problem as well. But the bottom line is that if you're worried, you want to have a physician evaluate them.
Yeah, absolutely. A really interesting question just came in, and it's a doozy a little bit. So in someone with a 22 millimeter Chiari without a syrinx, found incidentally without symptoms, obvious anyway, is that someone that would be likely recommended for surgery just due to the size of the Chiari? No.
No way. So one of the phrases we have in neurosurgery is the enemy of good is better. So if you're good, we're probably not going to make you better, and we may make you worse. So if you're asymptomatic, now the question is, why did you have the MRI done? But assuming, the current definition of a Chiari I malformation is 5 millimeters of cerebellar tonsillar ectopia. That was chosen nationally. When I was in training back in the 90s, any degree of cerebellar tonsillar ectopia was considered a Chiari I malformation. Now we have this gray zone, what's 0 to 5 millimeters of cerebellar tonsillar ectopia. A lot of us will use the Chiari 0 phrase, although that's not a nationally recognized phrase to use. It is, and I mentioned this earlier, but it is clear that the more cerebellar tonsillar ectopia you have, the more likely you're going to have symptoms. And 22 millimeters is pretty impressive. But I can tell you, I have patients in my practice that have 22 millimeters cerebellar tonsillar ectopia, and we never did anything, and they continue to do fine. My personal preference, and again, there's not great literature on that. My personal preference is that I usually repeat an MRI in 6 to 12 months. And the reason I do that is if that's your first MRI, you want to make sure that you're not having progression. Remember that the accuracy of an MRI is only 1 to 2 millimeters. So if you were 22 millimeters on your last one and you're 20 millimeters next time or 24 millimeters the other time, that's only within the accuracy of the MRI. So you really want to be paying attention. And the numbers, remember Dr. Vuong and I are pediatric neurosurgeries, although we do adult Chiari work as well. The number is something that we focus on nationally a lot. It is helpful, but it is a guideline. It's not a direct cutoff. And in kids, it's not very helpful at all, because if you measure anything on them, measure their fingers or toes, that's going to grow as they grow. So the hope is that this is going to be in the same location. So if it's the posterior arch of C1, then you expect to see that in the same location in a year or two. So I see that I see some of those things popping up. So in a 17-year-old, like I said, I've got 7 kids of my own. If she did fine with the MRI, personally, it would make me feel better to repeat an MRI in 6 to 12 months. I would certainly get copies of that MRI and make it part of her permanent medical records. And I recommend that for everybody. We'd like, one of the things that Obamacare I was hoping it was going to do was get a common platform so we could look at the MRIs nationally. We can look at our ATM numbers anywhere in the world, right? But we can't look at our imaging studies anywhere in the world. So it's a little frustrating from both a patient and a neurosurgery standpoint. So get a CD-ROM. It comes with its own built-in software, so any CD-capable computer can boot up those pictures. You'll want to, personally, I like confirming that things are stable in 6 to 12 months. That is now beyond the science of medicine and into the art of medicine.
Yeah. Oh, that's interesting. So just in the chat, the initial MRI showed it at, I think this is supposed to be millimeters, 3.2 millimeters, unless it is centimeters. With a searing. No, centimeters. Okay, that's interesting. With the searings, but it was not complete imaging, I assume, not the complete spine. So that's odd. That's a good question, though. So can the size of the Chiari change drastically, or?
It can, but that's rare. But that is why you follow up. So that was something that Dr. Vuong and I were talking about. I do like following my patients just to make sure that things don't get worse. If you see further cerebellar tonsil ectopia, it makes you worry, so you pay a little closer attention. It's rare that you see ascent of the tonsils, but sometimes you will. So I've had a couple of patients whose Chiari went away. Now, remember, I've followed over 1,000 patients, so you're looking at less than 1%. But again, it just gets back to us not completely understanding. Yeah. So when you don't completely understand, what do? You repeat images. Yeah, and within a month, that's very rare. So there was we had intraoperative MRI in Florida, and one of the things that we were looking at was how do you decide who to open the dura and not open the dura. This was before this study came out showing that there was statistical improvement if you open the dura. But we know that many patients will get better if you don't open the dura as well. So we're opening the dura in more patients than it needs to be opened on. We just don't know how to select that patient population. So the idea was that we were going to do intraoperative MRI before bony decompression and after bony decompression. And literally the month we were getting ready to start the study, to get the approval for the study, this was about 5 years ago now, the group out of University of Virginia published a study where they found they were looking at flow through the around the Chiari at the craniovertebral junction. They found that positioning made more of a difference than bony decompression or not bony decompression. In other words, if you were more flexed, you were essentially pulling the cerebellar tonsils up a little bit more, and if you were more extended, you were pushing them down a little bit more. So with that degree of change, I would wonder if there was some positioning change as well. And I would certainly have, yeah. So Dr. Shiflett was part of the team. Yeah. UVA is where I did my med school back in the 80s.
Oh, really? So a question came up. I don't know if you'll be able to see it because I think it was sent privately. But in patients that aren't young children, this is kind of like getting to age questions. I also had a different question I wanted to ask. Is there a particular age that you see onset of symptoms? And then my question was, does age matter in surgical recovery?
Yes, adults are much whinier than kids. Kids do amazingly well. It hurts. And this is one of the more uncomfortable operations we do. So it hurts. What hurts in surgery is muscle manipulation. So we have to move the muscles to the side. We put them back when we're done, but we're moving our heads all the time. It hurts to move your head for a while. So from a neurosurgery standpoint, there's not a lot of muscle in your head. There's a lot of muscle in the back of your neck. So it is an uncomfortable operation. Certainly any secondary medical issues make things more difficult as well. But there's no cutoff. I mentioned earlier, most patients that we talk about doing a decompression on, it really is based on symptoms. So it's part of the discussion you have with the patient. Many of the patients will come in and say, well, I've had migraines for my entire life, and it's not really migraines, it's Chiari headaches, and they just hadn't gotten the MRI before. We're imaging everybody now. Well, we're imaging a lot more people now than we were before, so we're picking up a lot more Chiaris. So no problem. Yeah. Everything okay?
Yep. Duty calls.
So this question was age. Is there an age issue in terms of healing, recovery, and surgery? So my answer was Kids tend to recover much better than adults. It is an uncomfortable operation.
True.
So to finish up my thought on that, I'll operate on anybody with symptoms, but I'm much more reluctant to operate on an elderly patient. And the older I get, the older the definition of elderly becomes. So probably if you're in your 60s, it really depends how much it's affecting you. If it's preventing you from your routine activities, it's a discussion we can have. And in terms of what we do, it's a pretty safe procedure. So we're operating around the brain, not in the brain. And so this is not true brain surgery, it's skull surgery. Again, we're working around it. So I've never had an issue with permanent damage in post-op related to the Chiari. I have had one Chiari patient who had a stroke, probably related to anesthesia, not related to surgery.
So I guess is there a usual age range where you see these Chiari patients specifically, or no? Is it kind of run the gamut?
So I think that we tend to see these in younger patients, and so I kind of getting to that same question and alluding to that all those same things about where the cutoff is. I guess once I start to see a patient that's 60, 65 with Chiari or older, I hesitate to jump right to surgery for them, because I want to make sure that they don't have something else that's mimicking a Chiari, because we tend to see these in 40s, 30s, 20s, that age range in adults, and then in children. So this does, and which kind of leads to that pathophysiology being congenital. Again, we see this at the earlier ages range, not like my spine patient population, which tends to be 65, 70, where the age and wear and tear of the joints is starting to cause problems with the spine. This is towards that congenital side. So that's where if I start to see patients who also have back problems, that makes me think like, oh, there's probably not the Chiari. And so, yeah, we do tend to see these in a younger population.
So one of the questions that came in is kind of interesting because it gets into your gray area that you're talking about here. So a 50-year-old patient presents with like 6 millimeters of herniation and a CXA, so a clival-axial angle of 114, but their symptoms are manageable. So is that the kind of patient that would get a surgery, or only if they worsen?
Yeah, so I'll jump in on that. For that patient to have surgery, they would need to push me to surgery. They would have to say, this is affecting my life so much, I need to have something done. And there's a lot of discussion about craniocervical instability and when do you go from the front and when do you go from the back. The back is so much easier in operation, both from a technical standpoint, from a recovery standpoint. Unless there's gross instability, I will almost always go from the back, hoping that I'll give them enough space that even if they've got some anterior, some front compression, will give them more space in the back. And then if that fails, we'll talk about going through the front. But going through the front, so the dens, the top of the cervical spine is basically if you could push your finger all the way through to the back of your throat. So we have to have ENT help us with that. They almost always need a fusion afterwards. It's a much more aggressive operation that we rarely need. So less than 1% of my Chiari patients do we end up fusing or doing anything transoral.
Yeah.
So my short answer on that one is I wouldn't do anything if they have manageable symptoms.
Right.
And honestly, that's true for almost everybody. The only people I try to push towards surgery is if you have a tethered cord, a big syrinx, progressive myelopathy.
Right. That's good. That's a good answer. I want to ask just one of the other questions that came in beforehand. So this patient had been having grand mal seizures, which I do want to ask about how common that is in this population, because I'm not sure. But they also had decompression, craniotomy. They experienced some hydrocephalus and CSF leakage and some encephaloceles. I actually am not sure what they are, so I might ask you to explain what that is for me. But could all of this possibly cause like memory loss and different kind of symptoms that maybe you're not used to seeing?
So we talked about that. This is one of the questions we had that we were able to review before, and it's not clear to me that they're talking about a Chiari in this patient. So an encephalocele is when a piece of the brain is coming through either the dura and usually the skull. It would be rare to have that in the posterior fossa. And they're talking about right frontal lobe issues. So I don't think I can sensibly respond to that entire question. I can address seizures. Seizures are a supratentorial issue, so they are above the cerebellum. If you have true seizures, and when she's saying grand mal seizures, I assume this is EEG proven. If you have true EEG proven seizures, they are not related to your Chiari. You can have seizure-like activity that looks like seizures that's coming from spasticity, myelopathy, and your Chiari. But if you have EEG proven seizures, it is not coming from your Chiari. So one of the things that Dr. Vuong and I were talking about, when we do a brain tumor and it's supratentorial, so if you have a right frontal tumor, we'll often start you on anticonvulsants, anti-seizure medicine, because we know that increases your risk of seizures. If you have a posterior fossa tumor, so in the back where the Chiari is, we don't start you on anticonvulsants because we know that does not increase the risk of seizures. So it sounds like there's multiple non-Chiari issues going on with that patient as well.
Right. I mean, I'm sure the answer is probably not, but is there any way to identify the difference between a seizure, or I don't know if you can explain what dystonia is and different seizures?
So the diagnostic, when we talk about MRIs, the diagnostic test of choice, when we talk about Chiaris, the diagnostic test of choice is an MRI. For seizures, the diagnostic test of choice is an EEG, so looking at electrical activity in the brain. Dystonia is a specific diagnosis within the myelopathy category. So you can have dystonia and have myelopathy. And so if you have dystonia, I would worry that there is some dysfunction. There is something that is preventing normal electrical activity from going from the brain down to wherever the dystonic area is, but your extremities typically. So something is going on there. Now, you can have Parkinson's disease. You can have other things with dystonia as well. But if the only anatomical thing that you're seeing is the Chiari and you have dystonia, I always have them see neurology. Sorry, we just lost our connection. Hopefully you can still see us. I always have them see neurology because we want to be sure we're not dealing with any other medical issues. And particularly in the elderly patient population, we want to make sure we're not seeing anything there. Dr. Vuong talked about secondary Chiari. So in kids who have intraventricular hemorrhage, who have hydrocephalus, so if you have elevated intracranial pressure, hydrocephalus is one of the more common things that we treat. That can push the cerebellar tonsils through the foramen magnum as well. And in that patient population, dystonia is more common, but that's usually from a supratentorial disease, not from the Chiari.
Okay. Is there any way to identify what those look like? So I keep coming back to if I was a parent and I was looking for these types of things or I guess even in my parents, like what are the clinical symptoms that you could see at home even that would lead you to want to go see a neurologist?
So dystonia is atypical movement, but everybody has cell phones now. If your kid is doing something funny, or usually if it's an adult, you can replicate it. But if your kid's doing something funny, atypical movements, take a video of it. Just take a video. We have lots of patients who come in and say, this is what's going on. Because if it's only happening once a week, it's unlikely to be happening during the time that we're examining the patient. So we want to look at it. We want to see it. We're doing all this online stuff. We use Epic as our electronic medical record. They can actually upload videos and pictures, and so we can look at them that way as well. One of the reasons I became a neurosurgeon is there is no Sherlock Holmes in neurosurgery anymore. You either have it on the imaging study or you don't have it. So the Sherlock Holmes of the neurosciences are the neurologists now. So in the dystonia setting, they'll usually do an MRI. If we don't see an anatomical reason for it, they go to neurology for the evaluation.
Do you want to add anything before I?
Oh no, yeah,
Yeah.
I'm
All
in
right.
complete agreement so far. Yeah, this is sounds good. Unfortunately, they're both episodic, and they can look very similar, and so that's where those EEG and neurology workups really start to come into play. I completely agree. In the era of cell phones, it's really nice to have a video, and neurologists appreciate that as well because they can really tell a lot by the stereotypical movements, whether or not they're leaning one way or another, but they can mimic each other a lot. Yes.
So for just as a side, so uh, in Cincinnati, where Dr. Vuong was, they have a very busy epilepsy program. It's important to note that in patients with true epilepsy, recurrent seizures, 50% of all initial EEGs will be normal. And the reason is they're not having the abnormal electrical activity during the time you're doing the EEG. Whereas Chiari usually doesn't fluctuate that much. So that's an anatomical abnormality. So much of the time it requires an additional workup. So they may be admitted for a longer term EEG. You can have an EEG hooked up as an ambulatory outpatient EEG as well. So if these are recurrent issues and the neurologist is concerned, having a single negative EEG does not rule out epilepsy.
Okay. I want to ask a surgical question. So if a patient has a syrinx, I would say in a child, and a Chiari, and you decompress the Chiari, but the syrinx doesn't go away, but they're feeling better, what does that patient have to do, or at all?
So there's many patients where we won't see the syrinx necessarily decrease in size, but the symptoms will get better. And in almost seemingly just as many patients, the syrinx does decrease in size initially and then stabilizes. So I would say that if the symptoms are feeling better, and this pretty much gets at the crux of Chiari in general, if the symptoms are improved, then there's nothing else to do.
Right, I would agree. And I think it's important we define syrinx, though. So many radiologists will talk about any fluid in the spinal cord as being a syrinx. So the spinal fluid is supposed to be outside the spinal cord, not inside the spinal cord. A syrinx is fluid inside the spinal cord. The accuracy of an MRI is so good, we can see these 1 and 2 millimeter fluid collections that most neurosurgeons will not call those syrinxes. I mentioned earlier that we used to shunt a lot of the syrinxes. Again, it's very rare we do those now. But putting a shunt is you're putting a tube in and then draining it somewhere. In the case of syrinxes, I usually do a syringo-subarachnoid shunt. I just drain it from the center of the spinal cord to the outside of the spinal cord, which is where it's supposed to be. And there's lots of different choices, but that's my personal preference. The diameter of the shunt is 3 to 4 millimeters. So when we used to shunt patients, 3 to 4 millimeters was considered successful treatment. So for most neurosurgical studies, the definition of a syrinx is at least 3 millimeters, and some use 5 millimeters. All right, so it needs to be thick enough. And what we really care about is the diameter, how thick it is. We don't care about how long it is. So the MRIs are so sensitive, we may see a central canal from the cervical to the lumbar region. If it's 1 millimeter, it is almost always asymptomatic. And if it is causing symptoms, there is no surgical treatment for it. It is medical management for myelopathic pain.
Yeah, that's really important. I feel like every once in a while we try to talk about, but I guess I'm going to stay on syringomyelia for one more question because it's kind of a complicated thing. If a patient only has a syrinx, no Chiari, they're having, I guess, typical syrinx symptoms, whatever you want to call those. Is there anything that neurosurgery can do for them, or should they be managed for that pain or medically?
I'll jump in on that one. I would make sure they've maximized medical management. So you want to have them see neurology, and you want to make sure they've gone down that pathway completely. If the symptoms persist and the syrinx is large enough to consider shunting, so again, 3 to 5 millimeters at least, I do a couple of things. If there is no Chiari, I still like another setting I like doing a cine MRI. So is there an arachnoid veil, or is there something else that may be blocking flow of spinal fluid that we just can't see on the MRI? If you have blocked flow, then that would be an indication. to essentially do a Chiari decompression. You can call that a Chiari 0 or whatever you want, but a posterior fossa decompression to give them more space and break up the arachnoid veil. And that success rate in the setting of a syrinx should be about the same success rate as surgery for a Chiari as well. So again, if it's myelopathy, you're looking at 58% by the Chiari Severity Index success rate. I have a great deal of reluctance to putting a syringo subarachnoid shunt in. So the Chiari decompression we're talking about, we're operating on the skull, the dura. We see the brain, and maybe we're touching the brain, but we're really not invading the brain. Because a syrinx is in the center of the spinal cord, in order to put a shunt in there, we have to go through normal spinal cord tissue in order to get the shunt in there. So there is a higher risk of neurological damage with surgical placement of a syringo subarachnoid shunt than there is for a Chiari decompression. So you're basically trying to see, is there anything else going on? You want to obviously make sure you have a head MRI. If you didn't see the Chiari presumably made sure they didn't have hydrocephalus or other secondary issues as well. But I would, as much as possible, try to push patients away from surgery. The syringo subarachnoid, syrinx anywhere shunts, they're thinner shunts than the ventriculoperitoneal shunts because you don't want to put a big tube into the middle of the spinal cord. That also means because they're thinner, the diameter is less and the failure rate is higher. So we look at that. We usually will sew them into the arachnoid. So that's one of the things we use the arachnoid for, so it doesn't slip out of the hole we made it. The most commonly used syringo subarachnoid shunt is called an Edwards-Barbaro shunt, and it's a little T shunt that you sort of bends. You put it into the syrinx, it then straightens out, and it's got a T piece that then comes out of the syrinx itself. We use so few here. We've got 2 in stock, and they're both about to expire, and they're good for 5 years or something. So it tells you an idea of how few we use. Most of us try to avoid those. I used to put in a lot of those back in the 90s. It's rare. So Dr. Vuong's been here a year and a half. We put in 0 so far.
Yep. Yeah. I guess there was a follow-up to that. So how common is it to see a syrinx with no apparent Chiari? Is that a common thing, or is it kind of relatively rare?
Yeah, uncommon.
Very uncommon. So I'll see 2 or 3 Chiaris a week at least. Syrinx without a Chiari, I've seen 2 in the roughly 2.5 years I've been here.
Again, that gets back into the definition of what we consider a syrinx. So
yes.
I've seen quite a few syrinxes or syringohydromyelias or whatever terminology we're using right now. And the radiologist is calling it that, and I don't think Dr. Trumble or I would either one of us would have called it a syrinx had we reviewed it. And again, it really just comes down to practicality. You can't shunt that, and it's probably not even causing symptoms that small. So is it really a syrinx?
Right. So we'll see patients with myelopathy with a visible central canal, a 1 or 2 millimeter thing. I wouldn't call that a syrinx.
Do you generally look for maybe another diagnosis in that case, or do you just chalk it up to idiopathic?
No, I send them to neurology. I send 100% of those patients to neurology to get an additional workup. And part of the frustration is, so the MRI, unless you're particularly claustrophobic, is a pretty simple study. If you're having myelopathy and you're not finding an anatomical issue, they'll often do EMGs. EMGs can be punitive in some patients. So an EMG, you're putting needles in and shocking and looking at the electrical activity. But it's the difference between looking at the anatomy, which is what the neurosurgeon is looking at, and looking at the function, which is what the neurologists look at. And the truth is, we care about the function more, right? We don't care if my brain looks funny or Dr. Vuong's brain looks funny, as long as they work normally. So we're paying attention to the function, and getting to the function often is what the neurologist is helpful with.
Yeah. To that point, there's another question I want to ask, but I really want to get to this first because it's so important. And I know it's really hard for patients to navigate. So say it's not an anatomic issue, it's purely functional. They need to find a neurologist. How do they do that if a lot of neurologists either don't understand Chiari or don't usually treat it, so they're not super comfortable doing anything that doesn't involve writing a migraine prescription or something like that? How do they navigate that? It's so hard.
So in Florida, we ended up hiring 2 neurologists into our practice who would pay attention because we couldn't find anybody who cared that much about it. It's a difficult diagnosis that takes a lot of time, and oftentimes you won't get an answer. So I don't have a good answer to that other than to say, go to a couple neurologists and see who you like. Again, when you call, make sure that they know how to say Chiari, make sure they know how to say syrinx, make sure that there's certain basic things. But that is certainly a setting, and truthfully, with neurosurgeons too, you want to make sure you're finding somebody you're comfortable with. But I think with neurology in particular, it often takes seeing a couple of guys or a couple of providers to find somebody that you're comfortable with.
Would you say the same would be true maybe for pain management or even PT? Maybe PT would help?
Yeah, so often we'll work, and again, it depends on the symptoms, but PT is a nice non-invasive treatment. PT, OT, speech therapy if swallowing is part of the issue. So again, you want to make sure that you've done all the non-surgical stuff before you consider surgery. And certainly if you don't see an anatomical issue, then going down that pathway is appropriate.
Okay, so the last couple of things I kind of just wanted to talk about are the burgeoning research areas. So cognition, particularly there was a question about cerebellar cognitive affective syndrome. So it's Dr. Schmahmann out in Boston. How does that relate to post-operative Chiari, if you believe it does at all?
That's an awesome question. The tough thing about cerebellum and cognitive issues is that we're really, again, this gets back to the black box thing. The big picture is that we really don't understand all the connections yet. We're working these diagnoses out, like you're saying, and there's things like cerebellar mutism that we still don't even understand why that happens, and that's a diagnosis where we can see sometimes in kids, particularly with Vermean tumors, so tumors in the middle of the cerebellum. When we take those out, they can wake up and not speak. There's no speech center in the cerebellum that we've mapped out, and so then why can't they talk after we do that? And it's a rare diagnosis, but it does come up. And so there are cognitive and speech functions as part of the cerebellum, but it's still the black box. And what makes it even weirder, and this kind of gets back into that seizure activity that we were talking about before, the infratentorial space and the cerebellum are all inhibitory only, and that's why we don't see seizure activity. It's an excitatory problem. But why does inhibitory mechanisms cause problems with speech? Why do they cause problems with cognition? And as we're getting this mapped out and figured out at the basic science level and research level, we're figuring that out more. As far as practicality goes, I haven't changed my practice or done anything effective. Do people wake up a little bit more foggy after surgery? Yes, but a lot of times I blame that on the anesthesia.
Yeah, I would agree. So with pediatric brain tumors, cerebellar mutism is a well-described phenomena. So as Dr. Vuong mentioned, typically the midline Vermean tumors, the more we split, the higher the incidence of cerebellar mutism. We don't get that. Adults don't have that problem. Kids do. So there is some pathway that has not been mapped out that's probably not present in every kid that causes cerebellar mutism. The brain is such a big black box. I don't think what many patients describe is going to be the same in everybody. And by that, I mean there may be pathways that some people have that other people don't. And so one of the things that we are working on, I'll tell you, part of my frustration in neurosurgery is we have gotten very good at the engineering. Our MRIs are infinitely better than they were before. CTs now take seconds where they used to take half an hour. We are much better at the engineering. We're minimally better at the anatomy. So the biological issue is still in its infancy. I'm going to be geeky here for a minute, but one of my favorite movie quotes is back from one of the Star Treks. I think it was Star Trek 4, where they go back and save the whales. This came out in the 80s, and Bones, one of the red shirts, is hit by a car and is in the emergency room, and they say he has an epidural hematoma. Bones, the doctor, goes and says, "I've got to see my friend." Well, no, he's got to have surgery right away, because we do surgery right away on those. He uses his tricorder. The guy gets better and walks away, and as they're walking away, Bones is saying, "The barbarians of this age would have drilled a hole in your head." Well, we're still the barbarians of this age. We are getting better. So we are using more and more tractography. We are looking at where the connections are occurring. It is not the same in everybody. It is easier for us to look at the tracts that are more consistent. The motor tracts are more consistent. The speech and the dominant temporal lobe. We can look at that stuff and see it. There are certainly many patients who describe issues with the cerebellum, and all we can say is those pathways have not been adequately characterized to be able to let you know what the risk is. Theoretically, we become more hardwired as we get older. So the way we learn is not that we create new connections, it's that we cut down the number of connections. So babies, when they get excited, everything fires. You have a Moreau reflex. And as we age, you have fewer and fewer connections. That's why kids tend to do better with head injuries or brain tumors, is because pathways that would have been cut off in adulthood are preserved, because the ones that were injured with the injury or the tumor or whatever are blocked. So I'm giving you a long answer to say Chiari is in its infancy. The understanding of how the cerebellum affects cognition is at least a generation behind that.
Yeah. So clinically, excuse me, when you're using outcomes measures to see how your patient's been doing before and after surgery, I know that's something that would theoretically help advance the research as well. But is there any clinical utility, I guess, to specific? I know you mentioned the Chiari Severity Index, but I guess that's kind of more prior to surgery. What do you do long term?
So there's a Chicago outcomes study, and actually just this month in our, I think it was the White Journal, but either Journal of Neurosurgery or Neurosurgery, those are our two most prestigious journals. There was an article looking at Chiari's and trying to compare Chiari Severity Index and Chicago Outcome Scale, and there was no consistency in that study. So we don't know for sure, and we don't have a consistent scale. I use the Chiari Severity Index because I think it's the best we have now. There are other scales out there. I'm not aware of anybody who is doing, for instance, neuropsych testing or IQ testing or looking at before and after. That would all be interesting things. The reality is that's not paid for by insurance, and if it's not paid for, it's not valued. And so unless we have studies showing that it's necessary, which we don't have yet, we're still a long way from being able to use that. So it would be nice. It'd be nice to do. We were doing studies for a while on our epilepsy patients. So in epilepsy, the surgical treatment is cutting out a piece of the brain. You would think that that would affect IQ. Of course, reducing seizures helps as well. But we have problems getting consistent neuropsych, and we had a neuropsych, one of the best, in my opinion, one of the best guys I've ever worked with, and he spent a lot of time doing it, but there was minimal compensation for it. So that's unfortunately part of the frustration of where we are. That's where we need CSF and all these people to do more studies.
Yeah, I'm leading this a little bit because I'm the hugest geek about all this. I'm constantly thinking about ways we can improve our patient registry and different things like that to really.
Yeah, so we had a patient registry with our epilepsy patients that included neuropsych testing. Mm-hmm. But right now, most of us, including me, Dr. Vuong can say if he does more, is talking to the patients. It's a very subjective answer. You know, yeah. How are you feeling today? How's your headaches doing? We do a physical exam, but we don't check their IQ. We want to be sure they went back to work. But if they're significantly symptomatic and we reduce their symptoms, then they hopefully are functionally better, but there may be underlying issues that we haven't assessed.
Well, yeah, and measuring it is so difficult. So,
Yes.
I mean,
Yes, it's where you need a neuropsychologist. A neurosurgeon's not the right guy to be testing that.
no worries. So a last question kind of gets to what we keep revisiting this entire time is definitional. So a question came up in the chat that says the term Chiari is overloaded and non-descriptive. How do you feel? Yeah. How do you feel about developing different terms to distinguish between like a small skull shape found in infancy, so congenital, versus like that, what you talked about earlier, that pulling or the pushing down? Like, so I know in our group, I believe you've met Dr. Bastorf. He's considered calling it a Chiari anomaly rather than a malformation because it's not quite necessarily what it is. But I wonder what you guys think about this.
Oh, definitional terms are tough, and as this population probably understands better than anybody, there's Chiari 0, 1, 1.5, 2, 3, 4, 5, and sometimes, there's other ones described, and so that really starts to beg the question. There was even a 3.5 described in one paper I found very arbitrarily or obscurely in the literature, and so the question starts to become like, why do you just call these all Chiaris? And are there subtypes of Chiari 1? And I think that's probably true. And as the data bores that out, it'll be clear. And that's what kind of gets into the crux of things. I've done a lot of research on Chiari 3, and that's like a completely different disease almost, and actually very rare. And the definitions are everything in that particular diagnosis, because we're using the wrong words in the literature, and we can't even clump everybody together because we're all calling it something different. And so, yes, I think that clarifying that definition and the wordage that we use, usually when I'm talking to patients, I even say, depending on what part of the country you're in, this would be called cerebellar ectopia or Chiari. And I was like, here in South Dakota, we all call it a Chiari, but it's not necessarily a symptomatic Chiari. And that's where we start kind of getting into all the lost definitions for sure.
Yeah. So the frustration is whether it's my belief that most have a combination of the cerebellar tonsillar ectopia and a small posterior fossa. But again, that's the pediatric skew to this. The reality is the treatment of Chiari in a 1, 0, 1, 1.52 are all the same. We do a decompression. So we're still pretty gross in this in terms of our treatment and in terms of our diagnosis. It would certainly be interesting from a study standpoint to look at that, but it is really difficult to do volumetric measurements. We don't know what a normal posterior fossa volume is. So we don't have those studies to say you're at the top quartile or the bottom quartile. A lot of it is very subjective, and as the neurosurgeon who's looked at 1,000 says, yeah, I'm worried that your posterior fossa is small. So yes, I would endorse improving the definitional issue, but then we're going to have a lot of conversations about how do you change the definition. We had a lot of conversation about going from any bit of cerebellar tonsillar ectopia being a Chiari 1 malformation to 5 millimeters being a Chiari 1 malformation, and we know patients can have 0 millimeters of cerebellar tonsillar ectopia and be symptomatic, and 22 millimeters and be asymptomatic.
Yeah. Well, I think the only way we're going to get to this is if people like you kind of work with us and help us figure out.
We appreciate all the work you guys are doing as well. We appreciate the invitation today.
Absolutely.
Yeah, of course. And so I want to thank you guys both for coming tonight. It was really, really great. This was a cool discussion. I know people have already thanked you in the chat. So anytime you want to do this again, we are more than happy to do this again.
Well, we appreciate it. We hope everybody stays safe, and hopefully we can do one of these in person next year.
Absolutely. Oh, actually, before we finish, I just want to do this really quick because I've asked other people this. So in the age of COVID, I know there's been remote consultations and things like that. And I know you've said that you travel from East and West South Dakota. So is this something that you do where you can maybe do a second opinion or anything like that?
So I'll give you my spiel. Part of what I did when I was in Florida was patients don't want to travel to me if they don't. You're coming to me because we're talking about surgery. There's no reason to come to me if we're not talking about surgery, because we can talk about medicine if you're sitting in California or wherever else. www.pedneurosurgery.net, pedneurosurgery.net is me. You can email me through the website. You can send either Dr. Vuong or I. So if people email us, or call the office, we will ask that they send a CD-ROM of their images. The neurosurgeon always wants to look at their insides. I always want images at least within the last 6 months. And then a one-page summary. I don't need, honestly, 1,000 pages is going to confuse me. So a one-page summary of current symptoms and current treatment. And then we're happy to review those without charge and at least give you a general answer, understanding that the best answer is to see a neurosurgeon. Yeah, so Caitlin put up, it's www.pedneurosurgery.net. That'll come to me, but Dr. Vuong and I will share stuff. And there's a link to email me. It's etrumble@pedneurosurgery.net. But you can if you Google me, you'll find me there, and you'll find Dr. Vuong if you Google him as well. He has his own website also. drvuong.com, right?
ShawnVuong.com.
Oh, there you go.
Just carry over from college, yeah.
Yeah, so we're happy to help, and it saves people from traveling. Since I've been here about 2 years, and we've probably seen patients from 15 to 20 states so far. So we're happy to help in any way we can. It's obviously a little bit more onerous to travel to Sioux Falls than it is to Orlando. On the flip side, it's 5 minutes through TSA, even when it used to be busy. So it's a very nice place to live and fly in and out of once you're here. But yeah, we're happy to review it. And honestly, I think there's a lot of neurosurgeons who do that, but we're happy to do it, and we don't charge. We try to help in any way we can, knowing that seeing the patient doing an exam is the ideal thing. So we give general answers, but we're not going to tell you, yes, you need surgery, or no, this other consultant is stupid.
You're not going to get that. But that's really good. And I do like to ask that just because I know there are a lot of patients that, frankly, they're in certain parts of the country where there's nobody around. Some people don't even have a neurosurgeon within a couple 100 miles. So, you know, this is really important stuff.
Right. Well, like we said, we're the only pediatric people in all of South Dakota, and then for hundreds of miles west as well for a couple of states. It's a sparsely populated area, but it is a long distance.
So, well, thank you. I actually mean it this time we're ending. Thank you, Dr. Trumble and Dr. Vuong, for answering these questions today. And again, anytime. This was great.
Perfect. Thanks.
Thank you.
Be safe, everyone.
Thank you.